welcome everyone to part 2, Unseen but in Need, Identifying Girls with Autism and Early Intervention. My name is Lisa Terry. I am on the Virginia Early Intervention Professional Development Team. I will help facilitate today. We also have on Corey Hill from our team who is in the background, and then we have Seth Buffkin. Seth is going to be able to help anybody with any kind of technology support that you may need. So feel free to message him if you do. Excuse me. And today we will be using the poll feature as well as playing some videos, and you'll utilize the chat, which I see everyone is getting used to right now. There's also an option for a Q&A on your toolbar, where if you have a question and you don't want to forget it, but you don't want it to get lost in chat, feel free to go there and type your question. And then at the end, we'll make sure that we get to all of those questions too. So we're excited to have you all. Just so you know, this is being recorded. And if you need closed captioning, feel free to hit the captions button to turn that on. And I am going to go ahead and pass it on to Savarna, Dr. Daria, who did a great job presenting on part 1. If you missed it, you can go ahead and access the archive on our VEIPD page. But Savarna, thank you so much for doing this for us. I know like everyone's really excited about this content and this topic, so thank you.
Thank you so much, Lisa, and thank you to your team. You guys have been incredible to work with. So I'm so happy to be back to talk about this. And I only get 1 hour, so I'm probably just going to jump in because there's so much great stuff that we're going to do today. This is who I am. I also want to share that I'm also a parent of a person with autism. And that kind of informs a lot about how I think practice and interact with people, either like families or the staff that we all work with. So I'm really excited to be here. Thanks again. So just before we start, I wanted to take a moment to recap what we talked about last month, because we talked about a lot. We started by speaking of how girls are different. They present differently than boys. And this sort of female autism phenotype that was defined in a paper in 2020, a Canadian paper, that kind of illustrated that, included talking about certain behaviors that they found that weren't captured when they used standard measures and assessment tools. And this included narrow interests that were typical for females, higher social attention and language ability compared to boys, motivation for social interaction that seemed to be more prominent in girls than boys, and finally the ability to mask behavior. And we'll talk about that a little bit more today. Secondly, there's a lot of overlapping, if you can go back, thanks. A lot of overlapping conditions that might cloud the diagnosis of girls, especially when the child has good language abilities, or they can mask or camouflage their symptoms. So because of that, there is inherently a gender bias that exists, and it often leads to later diagnosis because there's a lack of research around how these girls present. Finally, there's definitely specific differences that we see in the genetics and in the neuroanatomy of girls with autism. And it can be helpful to understand why they present differently than boys. And I think ultimately it's hopefully a important thing to help with treatment options in the future. Okay, we can go to the next slide. So we'll start with a poll today for everybody. I want you to start thinking about what barriers that you have, that you see as we move through our presentation today. So what do you see as barriers being of girls with autism. The fact that it's not being recognized by parents, the fact that it's not being recognized by providers in the community, like developmental pediatricians, being able to access a diagnostician or a developmental pediatrician, being able to access a therapeutic resource like maybe behavioral therapy, or cultural and language differences. I mean, these are just some. I think there's probably even more, but these are just some of the ones that I personally encounter. So, and my hope is that we can address some of these barriers today, the ones that we have some control over. I wish we had control over more of them, but at least we can be aware of them. And yes, girls many times don't look autistic, so it's hard to have discussions about this with families. Absolutely. So when we look at this poll, I think I'm gonna stop. Should I stop sharing?
No, it's sharing right now, so everyone can see the results
Okay, good.
now.
So I think everyone can see this. It's pretty prominent that a lot of you are seeing that it being recognized by parents is so challenging for you guys in your roles. Additionally, there's an access issue, right? Being able to see somebody to diagnose them is a big, big problem. And then almost half of you are seeing that it's not even recognized by the provider that's seeing them. And then there's cultural concerns. And finally, access to sort of therapy is a difficulty as well. Okay, great. So now we're going to just kind of briefly touch upon what we're going to talk about today. And I want to be very brief because there's a lot of good content, like I said. We talked about research last month, and today I really want to focus on the collective wisdom of families. And there will be a self-advocate speaking as well, which I love to hear. I think the videos and insight from families and also insights from you all, from my colleagues, my early intervention provider professionals are really informative. So I hope that you can kind of gain some insights from that. Then I think we'll talk about exploring the neurodiversity framework. It informs how we can best support and communicate with families when we're seeing families struggle with this information, as you guys all kind of talked about just now, where we can be the most empathetic and empowering. And we'll also mention some tools that we can use to support them, at least that we use in our system that might be helpful for you. The last two areas we'll talk about today is how to help families practically. So, just some different things that our colleagues have used that have been effective, and how to encourage families to advocate for their child to get the support they need, including an accurate diagnosis. Okay, thank you. So we're going to start with some videos of a self-advocate and some parent videos. And this is just a few snapshots of this experience, right, and this journey. Clearly not a fully diverse picture. And I will tell you, I looked very, very hard for a more ethnically and culturally diverse view of this, and it was very difficult to find minority voices. So I just want to give that caveat and keep that in mind as we move forward. Okay, let's start with this video clip. It's about 3 minutes long, and this is Olivia. She's a 25-year-old girl with autism, and she was diagnosed about 2 years prior to this video. And just while you're watching, think about kind of children that you might see that might have similar traits.
Jumping right into the video, trait number 1, I had delayed speech. This is something that is super common for people on the spectrum. We kind of have a delayed development when we start talking. So I didn't start talking until I was over 2 years old. I would just kind of mumble and point. My mom called me a mime because I would just point at stuff all the time. And then once I was about 3 or so, I developed like my own language, and I don't know what it was like. I don't remember, but my one grandma told my mom once that she spoke 2 languages because she knew exactly what I was asking for, even though I was not speaking English or any other known language. It was my own little language. But apparently my mom was fluent in Olivia speak. My one grandpa would say that I would just sit and take everything in like a computer. I didn't talk. I just would sit and not participate and just kind of take everything in. And he said I was feeding the computer. Eventually, when I did start talking in English and could form proper words and sentences, I was not speaking correctly. I had everything like back in my throat. So yes was a yak. I couldn't do forward sounds. So everything ended in like a g or a k. So I had to go to speech therapy before I started kindergarten. And speech therapy, I vaguely remember it, and I had a super cool teacher, and she had me talking totally normal in like 2 sessions, my mom said, and she said she was just a miracle worker. So if your child is not talking or is not pronouncing things correctly, don't worry, it's not a bad thing. Don't freak out, and don't be, scared to take them to a speech therapist, because they are super helpful and can really help your child. Childhood autistic trait number 2, I was super shy. This is another super common trait in autistic people, specifically females and girls. And a lot of girls will go misdiagnosed or undiagnosed with autism because people just go, oh, girls are just usually naturally shy as kids. But a lot of times it's a sign that they're actually on the spectrum. So I was painfully shy. Again, I wouldn't really talk much. Even when I could, I would always have to be by my mom's side. I definitely had separation anxiety, and I kind of had my mom talk for me. And basically, if it was someone that I didn't know, I would just kind of mind my own business because I just didn't want to interact with them. And that brings me to number 3, which is I didn't have a lot of friends growing up. And it's not so much that I didn't have a lot of friends, because I did, but I didn't really care about the relationships. That sounds really bad. I kind of talked about this in another video, but I just really preferred being alone, or preferred one-on-one time when I did interact with people. And I would kind of wander from friend group to friend group. I didn't just have one friend group. I kind of just wandered. And this is something very typical in young females on the spectrum. It's kind of another telltale sign, is we'll kind of wander from group to group on the playground and hang out with a bunch of different people, but we're not super close to any one person because we just kind of don't want to be. I was also just very uninterested in kids my age. I prefer to hang out with much older people, and I think I mentioned this again in a different video. And I was very uninterested in play dates or sleepovers. I was just like, nah, I'll just be alone. That's fine. That's fine. I don't need you. No.
Thank you. Olivia is so sweet, isn't she? So I think it's just so interesting to hear her talk about how her communication style, she was communicating, but it was unusual. It was different. And it just kind of illustrates some of the things we talked about last month, about, even though children like Olivia could be around other kids, they may not understand how to make those relationships work. And in her viewpoint, she didn't really care about making those friendships happen, even though she was around them. Okay, so we can keep going, and we'll see a new video, and this is about 2 minutes long. Again, this is Priscilla. She's a 17-year-old girl from Singapore, and her mom is going to speak about how her daughter presented when she was younger. It does end in a scene that distorts the video a little bit, because she's describing how her daughter feels in that sensory environment, just so you're aware. Oh, no, you can start at the beginning for this one. Yeah.
I'm just a little black rain cloud hovering above the country. And the rain cloud, there is honey, no none. Everyone knows that a rain cloud never is shiny, no none.
One key thing about her is that when she was young, she was a very aloof kid. When I tried to engage her when she was on a bouncer, she just gave me a very expressionless kind of look.
Priscilla.
She didn't respond to her name even if I'm just a few steps away from her. I think the key point was at 15 months when she can walk. She was basically walking away from people. So I brought her to the polyclinic at 20 months. And at 22 months, they gave her a diagnosis of autism.
Happy birthday to Priscilla. Happy birthday to you.
I think everybody tells you if you've seen an autistic child, you've only seen one, right? Because they're all so different. For Priscilla per se, from my personal experience with her, I feel that she is just trapped in a bubble. And for us to try to reach out to her, it's like there is this barrier. She doesn't fully understand what's happening on the outside because everything seems very muffled, very confusing, scary for her. Because definitely when I bring her to the bus stop, you could see that she's off. Something is really disturbing her and irritating her. And as she grows older, she can tell me it's the bus engine sound. She will use her two little pointers and press against her ear. The sound to them is very, very loud. So us it may be at volume 5, but to them it's volume 11. Maybe we can focus on one sound and screen out the surrounding sound. But for them it's all a mumbo jumbo, so it irritates them. So with better understanding, I realized that a lot of this was sound screens. But she's just an individual with memories, with feelings, with thoughts.
Thank you. Yeah, so just another viewpoint, and might want to consider who she reminds you of on your caseload. Okay, so we'll move on. The next are two videos of the same little girl. Her name is Madison. They're very short. One is one and the other 2 minutes. And they're just showing behaviors of a young child with obvious symptoms of autism. And the first one, she's about 7 to 9 months. Go ahead.
Hi everyone, and thank you so much for coming over to our YouTube channel to check out Madison's very early signs of autism video. I've been asked so many times by so many different people on TikTok if Madison ever showed any signs as a baby and if I could share those signs, and here it is. When Madison was 7.5 months old, she started crawling, but her crawl was kind of funky. She crawled kind of like a crab is what we called it. She had texture issues with touching her knees to the carpet or touching her knees to the floor. She just didn't like it, so she wouldn't do it. So she adapted her own way of crawling. Madison also loved being upside down all the time as a baby, and she was also an avid head shaker. Now at the time, whenever Madison was shaking her head, we figured she was just dancing because, of course, at that time, we weren't thinking anything of autism. We had no reason to. But looking back on old videos, we realized that Madison shook her head all the time. And then, of course, there is hand flapping. Madison is a happy flapper. You guys know that. If you guys are here from my TikTok, you guys know that Madison is a very happy, flappy girl. And she started flapping her hands around 8 months old. I don't have her actual 8-month-old video in this, but yeah. Then, of course, those of you from TikTok know Madison loves her toothbrushes. She loved them since 9 months old. She was also an avid W sitter, which is a sign of autism, and spinning in circles. All of you know Madison loved spinning in circles. She also spun in circles as a baby. She also had a thing with opening and closing doors and opening and closing cabinets. I really hope you guys enjoyed this video.
Okay, and we'll watch one more about Madison. It's interesting to hear what behaviors she's associating with autism. I don't know if I would call a W sitting a sign of autism, but that's okay. And just after this, we'll talk about your impressions of the videos and what you took away. So we'll watch this last video.
Bye-bye.
Bye-bye.
You clap?
5. Yay!
Yeah, baby. Good girl. Yeah, good girl. Maddie. Mama. Hey. 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 Madison. Hey. Madison. Madison. Maddie. Madison.
Thank you. Yeah. Just to speak, I think someone wrote something about the W sitting. I mean, I'm happy to have anyone speak about that who's more knowledgeable. From my perspective, you know, the research shows that there's definitely some gross motor delay early on, and some of that is something we see where there's a head lag that happens. But I don't think like every child, you know, who has low muscle tone necessarily has autism, and that's just what I was trying to clarify. So in terms of what you took away from those videos, maybe it's time for us to share a little bit in the chat if you thought it was if there was anything helpful or that you learned from their parents and self-advocate. Ah, okay. So, people are wondering still about the W sitting and connectivity issues. Um, yeah, it's interesting, right? Certainly, it's something that we see. I just don't know if I would say that it's, you know, a marker necessarily. Yes, all 3 children are very different. I think that's part of, you know, the interesting part of this is there's so much difference in how these children can present. So it's important for us to really think about that and the spectrum when we're looking at kids that are quite young. And yeah, I wish all kids could receive their diagnosis so young, like in Singapore. Maybe we need to all move to Singapore. But no, I think sometimes, like in Olivia's case, you know, her behaviors are quite subtle. And so it probably took seeing just the right person before they were able to get that sort of diagnosis. Yeah. So yeah, we'll kind of move on, and while you're kind of marinating and thinking about those different perspectives of autism in girls, I want to share some different parents' perspectives that I've talked to. If you want to go to the next slide here, we're going to kind of read some quotes from parents. She masks really well, but in times of stress has tics, outbursts, and sensory issues, like when the weather changes and we have to wear different clothes or different shoes. Essentially, this parent is illustrating rigidity that many girls might be experiencing, or those with autism who, you know, who may be boys or girls, doesn't matter. So if we can move on. we've seen more of the typical signs of autism as she gets older. But at the same time, some of her social skills have increased significantly, like making good jokes and but not knowing how to respond appropriately sometimes. I think that's a great coping mechanism for those with more subtle signs of autism, is to like use humor to help them relate to people because they want to relate. So that's really helpful. We can go on to the next slide. She has more repetitive behaviors than when she was younger, and she needs more comfort and STEM items more often and uses them for a longer period of time. Um, I'm curious if this parent's describing their daughter after they've been out in public and have had to maybe camouflage or mask during a period of time, and so they need some way to cope with that that stressful kind of public atmosphere. But this is very much in line with the research, right?
And Dr. Daria, there's a question,
Mhm.
I don't know if you saw it, about screen time in the chat.
Okay. What is the latest research on screen time? The little girl that regressed. Yes, that always hurts. I think in general, the last kind of research that I was reading, um, I, it does talk about the fact that increased screen time can lead to developmental delays for sure. I don't know if there's a specific connection between that and autism specifically. I think that probably hasn't been researched fully enough yet. At this point, my best answer is that we still have to look at genetics as our primary reason for some of this. And yes, absolutely, we need more research. There have been some newer studies that are looking at environmental causes, things like toxins in our environment, things like that. But I think, it's still emerging. So I don't have a 100% answer, but that's what I know right now. Okay, and finally, this last one, this parent's describing some strengths and weaknesses of her child. And this can make identifying autism quite tricky. I think in some ways this sounds a little bit similar to a child like Olivia from our first video, where they're not as interested in their peers, but they can appear to have a lot of great skills with their language, for example. Okay, so let's do another poll. So when you see girls who might have autism in your program, what is the most challenging behavior that you try to help parents with? Rigidity, special interests that are maybe excessive, the use of rote language, or echolalia, scripting, uh, parents being able to see what you're seeing, or something else. I see a question about, are gross motor delays more common in girls with autism? I don't, so that's one of the things that we talked about last month, where they were looking at the research there, and certainly they were seeing that there was more gross motor delays in some of those girls as compared to boys, which was very interesting in that article. And by the way, all the things that we're talking about, including all the research articles that I used for my previous talk, are going to be in that resource page. All the YouTube links, in case anybody wants to look at these some more and more in full. They will be on that resource page, so feel free to look at that at your, convenience. Okay. Looks pretty good. So I think we can see here that it's a mixed bag. parents seeing what you're seeing, including just, this is similar to what we were talking about earlier, right? Like trying to get parents to understand that this might be autism. Rigidity is a big one, it sounds like, and the use of kind of that scripting or rote language, and then sometimes special interests or other things. Okay, great. So when we go now and talk to our colleagues, I was really appreciative about getting some feedback from the people that I work with, and I'm interested to see if you guys can relate to the things that they said. These were some of the areas of weakness that they described when they were seeing girls with autism on their caseloads, as compared to boys. So first, there's more rote play and language that can be difficult to notice because it's more functional. Two, they can imitate. They do have more ability for that, but they might have trouble pairing imitation of maybe a verbalization with the motor action. And so they might be more separate. Again, we just talked about this. Rigidity was something that was brought up a couple of times, even around joint attention, like when they want to have joint attention with someone, or when they want to do turn-taking activities with someone. It's kind of even that rigid behavior around that. One myth that parents might believe is that those who have eye contact do not have autism, right? Do you guys hear that a lot? So the use of self-directed eye contact can also be something to look for. Social referencing can definitely happen with some of these girls, but it's self-directed. So girls can be more apt to maybe get in your space and use eye contact when that's important to them, but they don't maybe want to be directed or prompted by an adult or someone else, right? Again, inconsistency is a big one that I see with different people, in different places, or different environments, especially outside the home where it's more comfortable. So if their behavior is drastically different based on their surroundings or the people that accommodate their needs, that's something to take into consideration, and wonder about that. And finally, I think I just feel for parents so much, because to make behaviors manageable, parents have to do a lot for their child, and they don't often realize it, right? You guys, I think, can relate to some of these things. I'm interested to hear that, and we will talk about your experience in just a little bit. So we'll move on. And I want to share just, in terms of trying to communicate and support parents. And as you guys are all saying already, that helping parents recognize what you guys are seeing, what you're concerned about. This is a resource that our county is using in our program. It's called the Parents' Observations of Social Interactions, and it's part of a non-proprietary just developmental tool called the Survey of Well-Being of Young Children. And it can be used as young as 16 months and as old as 35 months old. It's another level 1 screener, just similar to the MChat, right? And I think everyone is pretty familiar with that from pediatricians who should be using it at 18 or 24 months in their offices. And I know a number of your programs in Virginia use this as well. So it's similar, it has similar sensitivity and specificity. It's only 7 questions, and it comes in multiple languages. And it's very easy to score. I'm not going to go into that today, but there is, again, a link to this in the resource page. And we generally just try to use this as a conversation starter when we're worried about autism and we want to talk to families about what we're seeing. I think the only question on here that I worry about in terms of girls is the last question. And you'll see it says, what are your child's favorite play activities? And I think depending on how the parents answer, like, and many girls might have more typical play activities, right? So this might not capture them. So that's just something a caveat to think about. So.
And you had
All right.
another question in the chat. Have you heard anything on PDA, pathological demand avoidance? Just recently heard about this as a potential piece on the spectrum, but being very common in girls, such as forced eye contact or avoiding demands more.
Ah, okay. So I'm going to talk a little bit about, I think a related topic which talks about, which is basically neurodiversity, and in terms of trying to reduce that sort of demand, because I think so this is what I think. When it comes to diagnosing a child, it's important to be specific about, or even in your shoes, when you're looking at behaviors that might be consistent with autism, to help relay that information to the parent. I think it's important to identify that, hey, their use of eye contact is different, right? And it's quite another thing to say, okay, we need to force in some ways them to behave in a certain way that I agree could be pathologic. So I think those are two separate things. And for now, what we're talking about is just kind of picking up the behaviors that are important so that we can identify them. Then later on, when we talk about goals and practically how to help them, then we need to keep that in mind and say, what's important to this family? And we're going to get into that in a little bit. So yes. And yes, the POSI, we don't use right now with all the kids at assessment. We're really using it specifically when we have a family and a child that has concerns of autism, so that we're using it as that conversation starter, but also as another tool to kind of solidify some of our findings. Okay, so this is kind of a framework that we're using right now. And this comes from a webinar that two of my colleagues, Sarah Kim and Jasmine Stevens, did. She's an occupational therapist and a speech language pathologist. And it was called Spotting the Early Signs of Autism. So we start out by having an open dialogue, right? Having a back and forth conversation so the family can be relaxed, ask questions as they want. That obviously is important to make sure the family feels comfortable with us. Then highlighting their positives, making sure that we emphasize that first is really helpful. And I usually do this when I'm talking about, when I am having a diagnosis conversation, I always like to start with that, because there's always positives, right? And we're going to talk about this a bit more when we talk about neurodiversity. Using specific examples of behavior that you observed during your time, and so that you can also explain to the parent what you're seeing and they've seen the same thing, and hopefully they did. Using something to support your findings, like an evidence-based resource or tool, and that's where something like the POSI might come in handy. So you can anchor your observations with something for the family, and that's valid. And then listening, of course, and watching for their response, right? How do they respond to this conversation? And is this the best time to proceed with kind of talking more about your concerns, or maybe it's something that needs to happen at another point, and that's okay too. You do have to kind of judge based on how the family is reacting. Encouraging, of course, them to seek a developmental pediatrician opinion for evaluation is important. And finally, just reminding them that we are here to support them. You know, this is a journey. This is not something that may end or even be found during their time in early intervention. It really does take a long time for parents to, you know, come to terms with information like this sometimes. Some parents are really on board and really want to know all this, but other parents aren't. And so time is really important, but we can still be there to support them. Okay. We are going to go to the next slide. And this is a colleague of mine, Carrie Latanwa, who is going to discuss concerns about autism with a make-believe family. It's about 3 minutes long. But while watching it, just think about your experience and how you have these discussions with families. If you know, what kind of language you use or tools that you use to help, and feel free to drop those comments in the chat and we'll discuss it after the video.
About some things we noticed today with Teresa and her development that are a little bit different than other kids her age. So we talked about when we went over the narratives, she kind of has that decreased joint attention, right? So she tends to focus more on objects when you guys are playing together. It's really hard to get her to look up into your face and to share attention around an activity with you, right? The other thing we talked about was she has a difficult time imitating. So she's not really imitating actions that she sees you do during play. Again, it's kind of hard to capture her attention. And we know she's having some difficulties communicating. We also went over those questions together from that parents' observations of social interactions, or the POSI, right? Where we were looking at things like, how does she respond if, you know, we point to something, or what are some of her some of the play activities that she enjoys. Right now she's really active, and you've noticed her kind of engaging in some of those repetitive things as she plays. So based on the results of the POSI and some of the observations that we saw today, we do feel like she has characteristics that are similar to a child on the autism spectrum. So I don't know if that's something you've ever thought of. Have you ever heard of autism?
No, I haven't. I'm not really sure what that means.
Okay, so you know, the one thing I want to make sure that you understand is that our program doesn't diagnose autism. So we're certainly not telling you that we think Teresa has autism today, but we see some of these characteristics. She was a little bit at risk on that screening tool that we used. So we want you to follow up with a developmental pediatrician or another specialist who can do some further diagnostic testing. Children on the autism spectrum often have difficulties with that foundation for communication, like we talked about, imitating, sharing joint attention, and those types of things. So because we noticed some of those things with Teresa today, we think following up with a developmental pediatrician would be a good next step. And there can often be a wait list, unfortunately, for those. So we wanted to mention that today. The other thing I wanted to mention, and we're going to go over her goals in a few minutes here, at the bottom of that page, I did put some additional resources. You know her so much better than we do. So I put a couple websites on there that you can go to find out a little bit more information about autism and see what you think. You know, you know her better, you know her best. So really looking at that and see if you think some of these things might describe her or some of them might not. That will give you more information to talk to either your pediatrician about, or hopefully a developmental pediatrician if you get an appointment to see one. Okay.
Great. So we could go to the next slide, and you know, if you guys have any thoughts about like what your experience has been when you're trying to have these conversations that are quite difficult. Does it look like this? Is there anything that you do differently? You know, if there's other resources that you use to help guide these conversations, feel free to share them in the chat. And if not, that's okay. We have a lot of other things we're going to cover in a minute, but I'm going to take just another minute to see if anyone has anything else going on, but otherwise we can move on. Okay. Yeah, I hear that, something about, you know, a little bit less jargon. And yeah, it's hard when there's Google around and there's misinformation. I agree. Yeah, and of course, this is a situation where she was just trying to illustrate in a short period of time. But I think that those are important aspects as well. Um, you know, I want to touch briefly on this. I'm not a neurodiversity expert, but I do feel like it's an important framework that we can use to help families in terms of communication. First and foremost, we're always going to highlight the strengths of a child when we're talking about them. And in terms of how we make goals or you know, try to focus our goals on things that are meaningful, and may even focus on developing known areas of ability that a child might have. So that means that this child with autism could excel in those domains and even gain some self-confidence and use the strengths that they already have to compensate for areas of difficulty in the future. Um, and what I mean by that is, you know, as somebody was saying before, like, we're not going to focus on, you know, don't, you know, use eye contact all the time when you talk to somebody. That's not meaningful. What's important is we want the child to engage, at least if the parents feel this way, to engage with other people, and how they engage that way can be individualized for each person. We're not focused on changing them. We're focused on allowing them to meet their potential, right? So just as the little girl in one of the earlier videos was described as a happy flapper, you know, she's happy and she can flap, and it's not going to functionally be a problem for her, you know, to make other skill, increase other skill areas. We don't need to suppress their uniqueness by masking or camouflaging different, like, repetitive behaviors or self-stim behaviors. Obviously, we want to always respect each family's cultural perspective, and the eye contact piece is a part of that too. You know, there's a lot of um, cultures that don't use a lot of direct eye contact, and that's okay. Um, and just in general, we are focusing on quality of life for both the family and the child and empowering them. Okay, so we'll go on to the next slide. And I just want to share this little, if you guys have seen this, I don't know, but it's a nice little representation of autism, where we don't use terms like high functioning and low functioning because, frankly, you know, every child has different areas of strengths and different areas of weaknesses, and it doesn't matter if they are intellectually disabled or not. They can still have all these different caveats, like a pie. So rather than describing them in high functioning and low functioning, try using terms like their strengths are X, Y, and Z, and their weaknesses are X, Y, and Z. So it's a more holistic way of talking about autism. And again, we're celebrating each and every one of them without judgment, but we certainly do want to identify who they are because it's important to them. Okay. So how do we put this into action? I think a lot of this has to do with things that we've talked about, right? We're going to focus on strengths first, and maybe even using some of these repetitive behaviors to teach skills. I was thinking about this the other day, like how many children you might know who are really interested in the alphabet, right? They love letters. I mean, we can use those letters in so many different ways, and I think you guys do this already, to ensure that they're learning self-awareness or social engagement. communication in different ways, whatever is important to the family, of course, and how non-functional play might benefit the child at some point in their life. You know, there's value to how they play and acquire information that we don't always have a lot of information about. I think it's important for us to keep that open mind and question, like, what is normal, right? What do we really have to be normal, like, in this society? We're all different, and I think that's the whole purpose of thinking about this in a neurodiverse way. So focus less on the diagnosis in some ways and more on the skills they want to see. What are the areas of development that this family and child wants most, especially in the times where the family is waiting and waiting and waiting for a diagnosis. It's more important to talk about that piece, in my opinion. So, all right. So if you want to type in the chat really quick, we're almost out of time. So I do want to make sure we have enough time at the end. But, you know, when you have a child or a family going through this journey, you know, how do you approach it? And would you add anything to what we've already said about this neurodiverse approach? You know, we know that masking is definitely something we want to avoid for these children, especially as they get older. Yes, yes. I have that problem a lot about families who are getting a diagnosis but are questioning it. And I think that's actually the piece that I was talking about, where if you have a family in that situation, focus less on the diagnosis and more on what are the things that you're struggling with. Let's focus on that. Let's help him or her get more acclimated in these different environments with these different people in these, you know, situations that are difficult for them, and, you know, keep supporting them in that way. And over time, hopefully it will become easier for them to see that those areas of, you know, that they're struggling with might be related to that diagnosis. Strategies for deterring masking. Yeah, I think the whole point of that is we have to continue to celebrate these individuals as individuals and not and like, okay, I'll give you an example. My son is 16. He does what I call joyful yelping at times. So we'll be out in the middle of public and in the middle of something that he probably everyone else is quiet, and he'll just yell out in the middle of it. And so at this point, I'm so used to the stares and all of that I think to myself, I'm like, I just use my own words to communicate what's going on. And I'm like, I know you're really excited right now, and that's so cool. And so anyone around me who hears it, maybe they're that much more educated. I don't know. But I think we just have to, as a society, decide that being unique and different is okay. I'm sorry, I can't read all of these. I do want to show you this video. It's of a mom who explains really well the value of getting an evaluation early. So we'll go ahead and get that started.
If you wait around to see if your kid is going to do something odd or strange, you are missing a huge window of opportunity to help your kid. I don't know how else to put it. Anne never ever did anything abnormal or strange, for the most part. You know, she seemed like a normal behaving child. She was loving, she was curious, she, you know, everything was kind of on track to being like normal. Nothing that would cause, you know, alarm or make us feel like, oh my God, like what is happening? If you're waiting for something like a breakthrough like that to happen, it's probably not going to. It's more about the absence of normal. It's about the things that she should be doing that she's not doing. And the way that you know that is having conversations with your doctor, or even just observing other children her age. Anne has a lot of cousins and friends and things at her age, so it was easy for us to kind of see and compare. You don't want to compare to the point where you are making yourself miserable and overly stressed out, but you do want to be smart and keep your eyes open and see, you know, what it is that your child should probably be doing. So that's key, and that was key for us in all of this, because once we understood and accepted that fact, we were really able to observe Anne in a productive way, in a way that we could identify where she needed help and to get that help for her. If it helps for any parents out there, you can always get the help privately. You don't have to tell your family, you don't have to tell your friends. We didn't start telling people about Anne's diagnosis until at least like 6 months into her therapy program. We needed to wrap our minds around everything first before we started letting other people into our precious space of vulnerability. You know, we needed to build up our strength and endurance against it before we started involving other people. Plus, I knew people were gonna have 1,000 questions, so I wanted to be able to at least address the questions from an educated perspective and not be like all ignorant like we used to be. I mean, if that helps, that's one way to kind of approach it. So when we talk about the symptoms and things, I know that there are, you know, autism is a spectrum, so there are various different behaviors and instances that may occur for some children that may not occur for others. I know that a lot of the things that I've read about what to expect from autism, we don't see it at all in Anne. And that's what made me really skeptical in the beginning, because I was just like, you know, going through the list, you know, I'm doing like probably most moms, you know, going through the list of qualifiers and saying, nope, she doesn't do that, nope, not that, nope, you know what, she doesn't have autism. You know, I did that before, I can't even lie. And one of the things were like, you know, the different behaviors that you hear a lot about or that you read a lot about, exhibiting violence or self-injury, problematic behaviors and things like that. Anne has never exhibited any of that, but things can change. I mean, she's only 2, she'll be 3 in October, but you know, things can evolve a lot later. I mean, that's how it happens, you know. One day your child can be this way, the next day they could be another. So we don't know what the future holds. We just know that we are emotionally prepared for whatever turns and pivots may take place with Anne's condition. And we just want to be, you know, on the up and up, be educated, stay, you know, in the know, stay up on all the latest reading and things and all the latest developments with autism, just so that we can better prepare ourselves for whatever the future holds. And another
Okay, we're just going to move on kind of quickly, but I really liked listening to her talk because she's a great advocate for her daughter. How can parents advocate for their child to get a diagnosis? Number one, know the right terminology. Have that parent start to understand what the DSM-5 criteria are so they can explain how their behaviors might be, and you might be able to help this, right? In reference to those areas. They go in with an advantage. Does the provider that their family is going to see have experience with nuanced autism or girls with autism? It's helpful to ask those questions ahead of time. And you as a provider can obviously help make sure the diagnostician sees the concerns that you have, whether it's through the parent or, you know, with permission talking to the diagnostician. If it's helpful, sometimes a teacher or therapist often fills out a standardized measure for more data for the assessment. And then finally, remind the family that even if a diagnosis isn't given right away, they can continue to follow up and get a second opinion. So it's important not to give up. So we'll just wrap up really quick. As we said, parents see concerns with their children early on, and girls are helped by knowing what's going on with them. You guys, all of the providers that we're talking about, notice these behaviors, and we need to be able to share them with parents. And finally, we can support families by still holding a neurodiverse approach and advocating for an early diagnosis. So with that, I just want to thank you all for joining me and thank all of my colleagues at Fairfax, and as well as the brave parents that all shared their videos online. Thanks again.
Thank you, Dr. Daria. That's always so full of wonderful information. Just a couple things. If y'all have questions, feel free to type them into the chat. But Just so you know, stay tuned for the next Talks on Tuesday. Our Talks on Tuesdays are always the first Tuesday of the month, so May will be our next one. And check your inbox, take the survey. We do take your feedback seriously, so take that. And then once you complete that, your certificate will automatically populate. And Dr. Daria, I know there was one question where somebody asked if you had a private practice, if you're available as a local resource for families seeking developmental assessment.
Oh, so currently I am only working for ITC in Fairfax, and so I don't see kids outside of that, but I do welcome you all as, providers to reach out to me if we ever want to discuss some of these things more. I'm very happy to do that. I think it's always fun to learn from each other. So
thank you. And it looks like our time is up. I'm going to go ahead and put Dr. Daria's email in the chat. So if anyone has any questions, feel free to reach out to her directly. And again, thank you, Dr. Daria, for sharing your knowledge and expertise and doing all this research for us. We appreciate it and hope you all have a fantastic day. Thank you.